Dear chairs, dear colleagues, I would like to introduce my PhD thesis about investigations of influencing factors on the fit of ceramic restorations. My name is Adrienn and I'm a dentist at the Department of Prosthodontics. My vision is to offer patients the highest level of precision and accuracy in dental restorations, ensuring optimal oral health and satisfaction, and my mission is to deliver evidence-based recommendations to dental professionals. Here you can see my two ongoing projects, from which the first one is the impact of finish line design on the adaptation of ceramic fixed dental prosthesis. This is a systematic review and a network meta-analysis. Ceramic crowns are extensively utilized in dentistry because of their outstanding aesthetic and excellent biocompatibility. The fit of this indirect restoration is increasingly important for long-time success. Biological failure of fixed prosthodontics is between 85 and 93%. Inadequate marginal and internal fit can lead to microleakage that can develop in secondary caries, pulp infection and endodontic treatment, or gingival inflammation and periodontitis. The type of finish line design is one of the most critical factors affecting marginal adaptation. So our aim is to investigating the different finish line designs on ceramic fixed dental prosthesis. Here you can see our PICO framework, where the population was the ceramic FDPs, and we would like to compare four types of finish line designs: the chamfer, the rounded shoulder, the shoulder, and the vertical edge preparation, and our outcome was the marginal and the internal fit in micrometer. Our null hypothesis is there is no difference between the different preparation designs, and our clinical and research implications is to help clinicians to make a proper selection of finish line design and to educate students with evidence-based knowledge and practice. We have conducted our systematic search. The last search was in this April in 4 databases with the following search key. After the selection process, I have 50 eligible full texts. We have lots of analyses, but due to the lack of time, I will show you the main ones. So our first outcome was the marginal gap. The marginal gap is the perpendicular measurement from the internal surface of the restoration to the preparation butt at the margin. The absolute marginal discrepancy is the angular combination of this marginal gap and the extension error, and the internal gap is the perpendicular measurement between the axial wall of the preparation to the inner surface of the restoration. The clinically acceptable range for the marginal gap is between 50 to 120 micrometer. For the internal gap is between 2 to 300 micrometer, and the suggested cement film thickness is between 50 to 100 micrometer. So our first outcome was the marginal gap. On the top left corner, you can see our network plot, where the orange circles represent the 4 types of finish line designs. The size of the circles represent the numbers of the restorations. The lines represent the direct comparisons, and the numbers on the lines represent the numbers of the studies. In this case, we have 28 in vitro studies with more than 1,200 restorations. Figure B shows us the SUCRA plot. The SUCRA value is a range from 0 to 100, and the higher the SUCRA value, the more likelihood that the therapy is in the top ranks. In this case, the vertical preparation gets the best results. And on the bottom, you can see a leak heat plot represent the relative effectiveness. Here, the effect was the mean difference in micrometer with 95% confidence intervals. If we see the first row and we compare the vertical to the rounded shoulder, chamfer, and shoulder preparation, we can see that the mean difference is between 6 to 12 micrometer, which is clinically not relevant and statistically not significant difference. Our second outcome was the absolute marginal discrepancy. In this case, we have 9 in vitro studies with almost 400 restorations, and in this case, the rounded shoulder preparation get the best results, but if we check the mean differences, we haven't found a statistically significant difference. And our third outcome was the internal gap, and in this case, the more minimal invasive preparations, so the chamfer and the vertical preparation get the best results. And if we compare the chamfer to the rounded shoulder finish line, we can see that the mean difference was 26.65 micrometer, which is a clinically relevant and a statistically significant difference. So the strength of our study that this was the first network meta-analysis about this topic with both direct and indirect comparisons. Articles were included with the highest evidence and with a variety of outcomes. The limitation is there's a high heterogeneity in the population and that variations in the measurement methods across the studies. So our main conclusion is that chamfer is the most effective preparation designs for minimizing the internal gap, the vertical preparation for the marginal gap, and rounded shoulder for the absolute marginal discrepancy. But despite the lack of statistical significant difference regarding the marginal fit and the superior internal adaptation observed with chamfer finish line, it supports its clinical recommendation. And optimizing the cement space remains essential to achieve a well-balanced adaptations. The implication for practice is that all the finish line designs we investigated were within this clinically acceptable threshold, so dentists must choose the preparation designs regarding the clinical situations. However, chamfer finish line is specifically favored for the overall performance and for the minimal invasiveness. The implication for research is that uniform and standardized study designs are needed to improve comparability, and we suggest micro-CT for evaluation method, and we need standardized and accurate thresholds. So we are happy to announce that our manuscript has been accepted this week to the BMC Oral Health. Yes. And my second topic is the investigating the effect of wax pattern manufacturing techniques on the fit of fixed restoration. So the main goal of fixed restoration is the close adaptation to the crown to the prepared tooth. Metal ceramic crowns and full ceramic crowns are the most commonly used materials for fabricating full coverage restoration. The first step to fabricate either a pressed ceramic or a pure metal, cast metal restoration is to make an anatomical wax pattern. Then we have to invest this wax pattern and burn out the wax to get the exactly negative layout of this pattern. And then we either have to press the ceramic material or pure the metal alloy to this cavity. So fabrication of this wax pattern is a critical step for long-time success. Conventionally, this wax pattern made manually by a dental technician. However, it has many human-related factors. But with the development of technology, there are different kinds of CAD/CAM technologies, for example, the milling or the 3D printing one to prepare this wax pattern. So our aim is to investigating these different manufacturing techniques. So our population is the wax pattern, and we would like to compare the conventional, the milled, and the 3D printed manufacturing, and the outcome is the same, so we would like to see the marginal and the internal fit in micrometer. We hypothesize that CAD/CAM manufacturing will decrease this marginal and internal gap of fixed restoration, and this is our clinical and research implication to decrease this gap. We have conducted a systematic search this September, and after the selection process, I have 48 eligible full texts. And we've just finished the grade assessment, and we have lots of subgroups based on the materials and based on the different kind of restorations, but due to the lack of time, I will show you the main ones. So regarding the ceramic restorations and in the marginal gap, we can see that between the milled and the 3D printed technology, we have found a 32.37 micrometer mean difference, which is clinically relevant and statistically significant. Regarding the internal gap of ceramic restorations, we have found a 2 to 4 micrometer mean difference, which is clinically not relevant and statistically not significant. And in the case of metal restorations, regarding the marginal gap, we also haven't found a statistically significant difference, like it's between 5 to 6 micrometer. And regarding the internal gap, is the same, so we haven't found significant differences between the manufacturing techniques. So our conclusion is that milled wax pattern reduced the marginal gap in ceramic restorations, and no significant differences in metal restoration between the CAD/CAM and the conventional wax methods. The implication for practice is that dentists should use the milled wax pattern for better ceramic restoration and durability, and the implication for research is that continuous research is needed to enhance 3D printing accuracy. So to summarize my two ongoing projects, my first project got accepted this June, and I would like to submit my second paper this September. And like my additional activities, I am teaching at the Department of Prosthodontics both gradually and postgradually. I'm taking part in different international courses to develop my knowledge and practice. And I'm also taking part in the Semmelweis Symposium poster section. And in the last 2 years, we have our study group published 2 Divan Journal articles as well regarding the digital dentistry. So thank you very much for your attention, and let me finish my presentation with the words of Richard Dawkins, that science is the poetry of reality. Thank you very much.
My question would be, regarding your second project, is there any difference between the marginal and the internal adaptation between the CAD/CAM technique or the heat press technique?
So regarding the manufacturing techniques, we made subgroups in the first project, because this was about the different preparation designs. And in this case, in CAD/CAM group, the vertical preparation get the worst results, but in heat press group, it get the best results regarding the marginal adaptation. And we thought, and we think about what could be the reason. And I searched in the literature, and I have found that in the CAD/CAM system milling machines, the burrs are usually rounded forms and minimum 1 millimeter. So it's very hard to mill these very sharp edges, so this could be the reason in the CAD/CAM technique. But when a dental technician do this manually, and if it's a very skilled dental technician, then he or she can build these very sharp angles in a very accurate way. So this could be the reason between.
My question is about your first topic. In your two outcomes, marginal and internal fit, the best results were not from the same group, if I remember correctly. How do you deal it in the clinic? So which one is the most important? Which one would you suggest to use?
Yes, we have found a little bit contradictory results regarding the marginal and the internal fit. And as I searched it in the literature, what could be the reason, I have found that maybe in the cementation process, as you imagine that during the cementation, the crown's internal surface moves closer and closer to the axial walls. And if there are this will increase the pressure during the cementation process. And if there are early contacts, for example, during the cementation, then it can block the cement flow. And this can open the marginal gap at the final cementation. So this could be the reason. And in the literature, they have found that in CAD/CAM technology, you can modify this cement gap, so you can type in what kind of cement space do you need for your restoration. And they showed that this balancing cement space was between 60 to 70 micrometer. And if they balance this, then the internal and marginal gaps were much better.
I have two questions. The first one is regarding the casts. So someone prepared them, or they were 3D printed, or gips cast, or this is the first one?
Yes, in the studies they reported that a very talented doctor prepared all the teeth. So with more than 5 years experience, this was a minimum, as they reported. But I know that it depends on the dentist, I'm sure. But I'm sure that in these studies they use the best skills, and these are in vitro as well, so it's easier to prepare in vitro than in vivo in patient's mouth.
Yeah, and the second one is regarding the impression.
Mm-hmm.
So hopefully they will somehow standardize. Maybe they use the laboratory scanner, or what do they use for impression?
Yes, in most of the cases they use the laboratory scanner as a standardized method.
What other factors do you think would influence the choice of finish line?
Mm-hmm. So as I mentioned, that they were all in the acceptable threshold, and dentists can choose between them. And it depends on the patient. So, for example, if you think about the tooth anatomy or enamel thickness or aesthetic region, then you can say that if there's a tilted teeth, or for example, you have to prepare the lower central incisors, then maybe you will choose the more minimal invasive preparation, because you don't want to open the pulp, you don't want to do an endo for these patients. So in this case, I think it could be a good choice to choose a vertical preparation as well.
I have only just one question. Do you think that the 120 micrometer threshold for clinically acceptable marginal gap is still relevant in modern dentistry?
It's a very good question, because this threshold is quite old. It was written in the 1970s, as I remember. And this threshold is based on McLean et al. Study, who investigated more than 1,000 restorations for 5 years. And they check what is the limit where there were complications with this restoration and when they haven't got these complications. And it's quite old because with the development of technology, CAD/CAM, new ceramic materials, new investigation methods, we have found that, for example, in the newest CAD/CAM technology, this marginal gap is between 30 to 80 micrometers, so it's much better than this 120 micrometer. So this is why I wrote to the research implications that we have to find, I think, new thresholds and minimize this marginal gap. So this is the most important, not to just be in the clinically acceptable threshold, but minimize it.
I was wondering, were you able to assess data on what kind of luting cement they used in these studies, and could you compare them? Because for ceramic restorations, we could use dual cure resin cement or resin cement and GI cement as well, and I think the viscosity, flowability are much different. So can we compare these studies?
Yes, thank you very much. One of the reviewers also asked this, but unfortunately we can make subgroups based on cemented and not cemented restoration, but because there are huge amount of cements that they have used, we haven't got the possibility to make subgroups. But this is a very important aspect, and thank you very much for this good advice, but unfortunately, we can't.
So your suggestion is saying, if I understood correctly, that 30 to 50 micron gap would be the preferable for producing this. Does it depend what kind of luting cement you are planning to use? Or since, as you have mentioned, in the milling system, we can set the gap for the cement between 120 to whatever 30. So actually the technician has to set up a certain number there. It's not like manually. When you are producing manually, it comes as it comes. But here you can exactly say what micron you want. So what would you set the machine for?
Yes, this setting was in general, so they didn't describe for what kind of cement. This was described for zirconia restorations that I have read, but they didn't describe what kind of cement, unfortunately. So I think this is the average that they calculated, that above this they get worse results, and under this they also get worse results. So this can be balanced, both of these. But thank you, it's a very, very interesting topic.
And one more question came to my mind. If these were these different restorations and they produced them with CAD/CAM technology, do you have information whether it was 3-axis or 5-axis milling machine?
Yes, fortunately, in most of the cases they use the 5-axis milling machines. This is the most precise, and in 1 or 2 studies they use the 3-axis. So this is why we can't divide them. But the most precise was the 3-axis. Yes, thank you.
So a couple of things. First one is, I noted that in your first study you had 50 eligible articles. So you're winning at the moment when I look at all the other presentations, which were less than that. So you had a lot more work to do. Can you just comment on why? Is it because your inclusion criteria were broader, or is it that we're doing a lot more better research in this area? I'm just interested in why it's 50 versus 8 to 10 publications.
I think this is a quite hot topic, because dentists would like to know which is the best choice for them. And in most of so in most of the cases, when you get the instruction for the ceramic materials, they just write, okay, use a chamfer or a rounded shoulder or something like that, but they didn't tell exactly what to choose. And I think this is why it's a very hot topic. And the other one is that in the last 2 years, they tried to find more information about the vertical preparation, because it gets back in the preparation designs from the very past. And they have found very good results with them. And this is why it was more investigated.
Thank you. And just to follow up, I think your findings have got a lot of clinical relevancy. And I really like things like international consensus guidelines in how we do things. Otherwise, if we leave it up to the dental professional, then they often say, in my hands, this works better, and that's why I do it. Mm-hmm. Are there international guidelines on the types of margins and the restorations for certain situations? And if not, or even if there are, can you see that they should be improved based on your findings from both of those studies?
Thank you very much. I haven't found these guidelines, so this is why I start to conduct this study, and I hope that in the future we can do a guideline based on my results. It would be an honor.
I think that's a fantastic idea, and get an international group, and which indeed you could possibly lead.
Thank you very much.
So your main outcomes are marginal and internal fit.
Yes.
And were they measured on each implant at one given specific point, or are these averages for every implant?
Yes, there were averages, so we used the means and the standard deviations in every crowns, and they measured this in different points, and they pulled the means from these ones. And yes, they measured the marginal and internal gap also from the same restorations. So, yes.
And is there some
heterogeneity?
Not that heterogeneity. I'm just interested in that. Is there a way that on one side it's really bad, but on the other side everything is excellent? Would you consider that good?
Yes, it could be. For example, in my practice, I think that the approximal part is always harder to do the preparation than in the buccal or in the lingual part. But these are in vitro studies, so I hope that two big differences I haven't found between the different points.
And my other question is that based on your plots, I think it was done by Noemi.
Yes.
Yes, so it's a Bayesian network methodology.
Yes, it is.
And how did you assess the consistency and inconsistency between the direct and indirect?
I've got the consistency table, and it shows the dots of different studies, and if they group together, then we can say that the network is consistent, and they were quite in the same spot.
Okay, thank you.
Thank you very much.